My name is Sebenele Nkambule. I'm a palliative care nurse under Eswatini Hospice at home. For today, I will be the facilitator for our session, our ECHO session for today. I would like to acknowledge the presence of ECHO India for their support. Thank you so much, guys. I would also like to appreciate everyone who have just joined. This is our platform to learn. So feel free to participate, and we encourage everyone to feel free and be active in participation. So for today, our topic is withholding and withdrawal of treatment. So before we start the session, I would like to ask everyone to make sure that your cell phone is muted, as well as to mute our devices. You'll only unmute when you have got something to say. Feel free to use the chat box when you want to say something. I would also request you to use the chat box to introduce yourself and everyone that you are with, because sometimes you find that there are many people using one gadget. So you can also state your colleagues with you, and also where you come from. Feel free as well to raise your hand when you have got something to say. I will recognize you and ask you to unmute yourself to say whatever you want to say. So now I would like to ask the participant to introduce themselves as well. We're still expecting others to join us as we continue with the session, and we're looking forward to the session. So I hope I'm audible enough as well. I will ask Mr. William Villa to introduce yourself. You just state your name, your position at work, and where you come from. Thank you.
Good afternoon, colleagues. My name is William Villa. I'm from Lubombo, specialty in anesthesia in our ICU. I'm also involved with palliative care, the palliative care team. I'm part of the palliative care team, and our model that we chose as the palliative care team is to work from ward to ward in the hospital. We don't do hospice at home. We don't do palliation under home-based care, but we are in hospital. We take care of the terminally ill patients and those who are in their end of life here in hospital. So thank you very much. I hope for a very good experience by joining this meeting. And of course, we do have an ICU in our hospital, so I'd love to learn a lot from today's topic. Thank you very much.
Villa, thank you so much for introducing yourself. May I kindly request Zinhlezwane to introduce herself?
Morning, everyone. I'm Zinhlezwane from RFM Hospital. I'm with Nansigelo Lontuli. We are both working at the palliative care unit at RFM Hospital. Thank you.
Thank you so much. Thank you, Zitlen Nansigelelo and RFM Palliative Care team. May I kindly request Horses to introduce yourself.
Social worker at the Malanda Public Hospital.
Thank you so much, Simpiwe. May I ask Bongegile Nkambule to introduce herself as well? Bongegile, may you please raise your volume so that we can hear you? I think we have a problem with hearing what you're saying. Thank you.
Hello, everyone. Hello.
Okay, thank you. I think we also have a network problem. Okay, in the interest of time, I would like to ask, sorry guys, with me colleagues, I have our team here, the palliative care team. I also have members of the team whom I would love to introduce themselves as well before we proceed to our topic for today. So I'll start with Mr. Bongi Mabuza next to me.
Afternoon, everyone. My name is Bongi Mabuza. I work as a palliative nurse at Hospice at Home under Hoho region. Thank you.
Thank you, Bongi.
Good afternoon, everyone. My name is Samelo Mukele. I'm working as a palliative care nurse based in Manzini region. Thank you.
Thank you, Mr. Okele. Mr. Damini.
Good afternoon, everyone. My name is Pennington Damini. I'm a palliative care nurse who is working in the Shiselena region. Thank you.
Thank you, Ngozi. Bongile.
Hi, everyone. My name is Bongile Simelane, here at Hospice at Home, a palliative care nurse based at the clinic. Thank you.
Thank you. Okay. So now we will get to the topic for today, which is withholding and withdrawal of treatment, and it will be presented by Sibongile Simelane. Thank you so much, colleagues. Over to you, Sibongile.
Thank you, colleague. Thank you, Selenele. My name is Bongile Simelane, and as a Hospice at Home, I'm here today to present this dialectic. Our topic is withholding and withdrawal of treatment. Our objective. One of our objectives is to understand. I would love you to understand and define withdrawing and withdrawal of treatment. It could be life support or the other therapy, and to be able to make the ethical decisions on withholding and withdrawal of treatment. With this one particularly, the ethical decisions, which also makes us as nurses to throw the towel at the end of our job. I would love you to follow what we are going to deliberate on today. Thank you. Our goal in palliative care is to maintain the quality of life while neither hastening or postponing death. I think this one is understood. Care should be taken, especially to our clients, and they are supposed to be, our care is supposed to be client-centered. As professions, we have a duty to provide comfort and relief. So at the end of our session, you understand why we have this topic now, withholding and withdrawal of treatment. The healthcare team has a major role in decision making. And you'll be able to understand the teamwork here as healthcare professionals. And the shift we usually make to solely the family, we would love to withdraw from there as professionals. We tend to shift everything at the end to the family. But now, I think this session of today will make us be part and parcel of the whole process until the end. As healthcare workers, we are supposed to be capacitating on withholding. We are supposed to be capacitated also on withholding and withdrawal of treatment decision making. Here we've got the definitions. What withdrawal of treatment means. It's removal of therapy that has become futile and prolongs the dying process. At the same time, after the two, we are going to just look at futile therapy. Withholding of treatment is not administering the therapy that is deemed not beneficial to the patient. And futility is any treatment that seems to be without benefit to the patient. There are no requirements of justification to sustain life at all costs. Withholding and withdrawal does not shorten or prolong life, nor hasten death. At the end, withholding or withdrawal of futile therapy from a terminal ill is not euthanasia, as some of our health workers might think. So as the team we are today, we are going to empower even the others. Let's see and let's look at withdrawing life-sustaining interventions. The complexity created by advancing technology is a situation of patients who have elected to forego continued use of life-sustaining devices in order to allow peaceful death. Here we remember as a team that patient involvement and patient decisions are to be observed. When life is dependent on active device operation, the result is more difficult challenges and unresolved questions. That's why at the end of the day, one would see person for himself throwing a towel. Some believe discontinuation of device is considered equivalent to an act of euthanasia, and that's necessary. No, it's not like that. Life-sustaining devices also have the potential to decrease the overall quality of life, especially at the end of life stage. Here we maybe take an example of a patient who is on O2 and for quite a longer time, maybe more than 3 weeks, that even that O2 has got effects on the lungs, and even the tubing has got an effect whereby you can find that some bacteria has been introduced into the lungs, and you find that your client complicates more and can even get pneumonia. Clinicians hold an ethical obligation to provide significant emotional support to those patients and the families. Remember, we say they've got this ethical framework whereby yes, we've got autonomy, and we should offer the beneficent to these clients and the family. And the family involvement, as we always say, is important. Let's see at the clinical responsibilities of withdrawing life-sustaining interventions. Here we'll look at we like to determine the exact status of the device operation. We should know what is it, how long is it going to be used, and what are the implications and any possible disadvantages to the client. The plan of adjusting the device should stem from a clear understanding of the patient's goal of care. Family, client involvement here is important, because at the beginning of everything, you create a good rapport with the patient, you explain everything, you involve the patient, and your client should be satisfied. And every time you co-relate or make some inputs, you should get power with the client and the team as well. Decision must be made in collaboration with the care team, that I've already said. Extra care must be taken into consideration to assure that the patient, family members, and entire care is in agreement. I've already said that. The timing of discontinuation must be carefully considered, and the plan to address likely symptoms put in place. As we said, an example of this O2, that where, okay, this one is addressing us on the withdrawal of the O2, and we should know the symptoms which can be there, especially the restlessness and the labored respirations and the infections, that we should be aware and take consideration of to take care of those symptoms. Let's look at withdrawal and withholding or withdrawal of treatment. As we all know that death is a natural end of life. So we should be calm and be able to assist the patient together with your team. Quality of life matters, not the time which is left too long. One point which is important here, I wanted to say whether it is appropriate to offer or withhold or withdraw a particular therapy depends on the balance between the possible benefit and the potential risk of the treatment that is in the patient's best interest. It will depend on the individual clinical circumstances. It is difficult and complex, yes it is. That's why I said at the beginning, we should be calm and know that death has to happen naturally at the end of life. Future therapy with no chance of benefit can never be justified. Here we as health workers, we sometimes get to a point whereby we got a push maybe by the condition that I have to do something, I have to do something, I have to do something. But remember, death is a natural, death is natural. at the end of life. Keep calm and assist. Let's look at our third point, which is futility, that is futile therapy. The right of a patient or family to accept or refuse therapy does not entail in the right to demand therapy, which the physician does not believe are medically justified. Yes, we know that the client has got an autonomy principle here, but then we have to play around, get the trust, also play the relationship patient care-based framework, so that we go at par, especially with the patient, the family, and the whole team, so that when you explain what is going to happen at the end of the day, you will be at par, meaning you gain the trust and the client will be in a position to understand, not to even push you to do what is not going to benefit the client. The well-established right to accept or refuse therapy stands in the principle of the autonomy. Okay, let's pass that. The principle establishes the duty to refrain from interfering in life choices of competent persons. It is thus a liberty right, not a right to demand access to any particular intervention. As we are at the end of our ethical dilemmas today, let's look at the ethical dilemma in futile therapy. Commitment to support patient autonomy has unfortunately led to the tendency to shift the responsibility of decision-making entirely to the patients and families. We've stated that at the beginning of our topic. Clinicians become reluctant to advise and guide patients and family in decisions instead of presenting options in a completely impartial fashion. I think that one is understood. Clinicians find themselves in a situation whereby patients and families demand therapy that will overweigh the benefits and have a significant probability of harm. You see now, there is a room where you have to stand still, calm, and be able to weigh the benefits and have a significant probability of harm. The frequency of futile dilemmas has led health organizations to develop policies of managing conflicts, that every time when we encounter a problem and it becomes unsolved, the next thing we decide to develop policies of for managing conflicts. However, it is more important to prevent futility conflicts from developing. As with most ethical dilemmas, effective communication and trust relationships are key. Let's prevent these futility conflicts. When the situation is such that the CPR or other interventions are no longer indicated, this should be stated. Patients and families should be asked to give permission to withhold or withdraw an effective intervention. That's why at the first contact, we have to get build a rapport, explain, make the patient understand, so that at the end of the day, you won't have problems. If conscious consensus appears to be rechargeable, other resources such as clergy or consultants should be utilized. That is, you remember on the previous slide we talked of health workers developing policies. Now, if, okay, those policies may be there, but then we still have the problems with these dilemmas. We tend to maybe have a lot of work to do, but then even then we can outsource such as getting a clergy and some other ethical consultants. Preferably, interdisciplinary procedural approaches should be utilized. Courts should be our last resort. The clinical decisions in making in futility, clinicians have got a right and professional duty to refrain from interventions that are harmful. It is essential to be cautious in judging interventions as futile. There may be treatments or therapies that often neither cure nor improve the patient's condition, but the effect are afoot to the survivor. And the claim of futility should not be used to justify withholding therapies in situations in which the clinician believes that the proposed therapy would accomplish its intended purpose, but resulting in quality of life would be undesirable. Judgments such as this reflect the subjective opinion and values of clinicians are not a value basis for withholding therapy against the wishes of the patient. Here we have an example of a scenario of which I would love you to take note and try and answer at your own pace, or maybe if time allows, we can get a response maybe from the chat box. Example of withdrawal of a treatment scenario. Number one, should a terminally ill patient receive antibiotics for a chest infection? Number two, how should renal failure caused by diuretic obstruction due to advanced cancer be managed? There are other examples besides this. NCDs are a problem outside there. We find that for the time with the diabetes and the family still continuing to administer those anti-diabetic treatment, what would we do? Thank you. That's the end of my presentation. Thank you for listening, colleagues.
Thank you very much, Bongile, for the lovely presentation. We thank the presentation. Well, at this point in time, I would like to ask our participants and everyone, colleagues, to, if ever you have a question, a comment, or an addition, or recommendation, please feel free to use the chat box and say whatever you want to say, as well as you can show by raising your hand so that I may recognize you, so that you can say something. May I kindly request as well that we also write our names on the chat box, as well as those that we are joining with. It's a request that I asked earlier. So I would like to say something in summary from the presentation, that in palliative care, the care should be client-centered. So we should make sure that we we involve the client in the care, as well as the family members. And extra care must be taken to consideration to ensure that the family, the patient and the family members, and the entire care team is in agreement. So everyone should be involved. As well as that, we should make sure that we explain everything clearly, especially in the issues of the therapies with the patient, because we have learned that sometimes clinicians find themselves in a situation whereby the patient or the family members will demand a therapist that will outweigh the benefits of the client. So it's important that we explain everything clearly and do our best to ensure that whatever therapy that we do or that is given will actually benefit the client and not harm the client. And clinicians or healthcare workers have the right and professional duty to refrain from interventions that are harmful or that would be harmful to the patient. So it is important that whatever we do, we make sure that it is of benefit to the client. I think that's all I can say about our presentation in summary, but I would like us to respond. I think there were questions. There was a scenario and there were questions there on the scenario, the examples. I would kindly request. Okay. I think we have something on the chat by Mr. Vila. I can't see.
Mr. Vila is saying yes, antibiotics should be given to terminally ill patients in order to improve the quality of life. The only time when they can be withdrawn will be at the end of life.
Okay, thank you so much, Mr. Mbila, for your response. Okay, thank you. I hope everyone is free to say whatever is thinking about the scenario. I wanted Mr. Mahlang to project so that everyone may see. Maybe we can, if we do have some minutes. But feel free to use the chat box if ever you want to communicate or to say anything. This is our platform, colleagues. Is there anyone with a question, colleagues? Or I can see a hand from Spula. Feel free to unmute yourself and say whatever you want to say. Spula. Okay, is there anyone with a question, colleagues? Suggestion, a comment, a recommendation? Anyone, colleagues? Yeah. Okay, Mr. Mvila, I can see your hand. Feel free to unmute yourself, say, and
good afternoon once again, colleagues. Yes, it's not a question as such, but I want to comment. We have had instances of, as you know, that my hospital is where we were admitting most of the ICU cases for COVID. So a patient with an obvious respiratory failure and nearing the end of life, maybe on a ventilator, you would see the oxygen saturation dropping for some time, because maybe, like we are saying, it's at the end of life. The respiratory failure is getting worse, and there's now obstruction. But you would see the teams doing their best in trying to resuscitate the patient at that stage. The saturation would go down, and then later on the patient would get to to cardiac arrest following the respiratory failure. So then we would start CPR. Then I was always asking myself, why do we have to do all this? Was it very necessary to do CPR for patients who first had a respiratory arrest, desaturated, and then now they are in cardiac arrest? So oftentimes we would resuscitate, and the patient would recover maybe for 30 minutes or so. Thereafter, it wouldn't last for 3 hours. So now it's very clear to me that some of these things, we do it for ourselves. We think we should do something, which is at the end a futile exercise. Thank you very much for the presentation. It's an eye-opener for some of the things that we go through every day in hospitals. Thank you.
thank you very much, Mr. Mbila. Thank you for bringing that up. I would like to give it to anyone from my team, and anyone may just, Mr. Mahlangu, do you have something to say, sir?
Thank you so much, Mr. Mbila, for that. It is true. Most of the time we subject our clients into trauma just to satisfy our hearts, and it's a common thing. And in those scenarios, is the issue of antibiotics. Sometimes at the end of life, if the antibiotic will not address the distressing symptoms, then we withdraw it because it's not beneficial. So that's one is true. And we need to be very careful. Sometimes people say, I was in a session where we're discussing withdrawal treatment, especially fetal treatment, and then we use this door to hide behind it. Let's say it's a fetal treatment. If I feel like I'm not going to be able to administer it, I will say it's a fetal treatment, even not doing assessment. So it's very important that we also do assessment. What Mr. Mbila is saying is that most of us during the COVID time would subject people into this life-sustaining therapy just for ourselves, finding out that instead of improving the quality of life, we are just making it worse and prolonging the death of the client. So I think one of the things we need to also look at is the thorough assessment. Before we justify treatment to say it is futile, we need to thoroughly explain to the patient the benefits and the futility of it. Before then we can say it's futile. And even before we administer a fetal product, we have to sit down and analyze it. What will it do to improve the quality or effects on the condition? If it's not going to change anything concerning the diagnosis, then it might be a fetal therapy. So it is true, Mr. Mbila. It's most of what we are doing. And sometimes we find that, especially when we are nurses, we feel like we cannot question the doctor because we are scared to stand for the patient's right and say, I feel we need to withhold this treatment for now. I don't see it working, or I feel this time around we need to withdraw this. I think we need to take that energy and be able to do the analysis and even to be fair, because sometimes doctors will do it just to defeat their own consciousness and say, I will give it just for the sake of doing. Yet in palliative care, I would say, let's not do things for the sake of doing it. That would be my input. Otherwise, Mr. Mvula has stated clearly everything. Thank you, Mr. Msud.
Thank you so much, Mr. Matlamu. If ever there is someone who wants to say something based on the presentation, please come in. May you write on the chat box. Well, in the interest of time, I would like to call upon the Hlatikulu team. I think Bongegile will present for us a case from the Hlatikulu team. Over to you, Bongegile. Yes.
Hello, everyone.
Hello.
Can you hear me?
Bongegile. Yes, we can hear you.
Okay. Okay, we have a case from Hlatikulu Government Hospital. A 52-year-old female with a diagnosis of brain tumor. So the main problem or concern we have about this patient is that the relatives want the patient to be operated to remove the tumor, yet the neurosurgeon team said they will not do any surgical intervention due to the patient's condition and prognosis post-operation. The chief complaint of the patient were body weakness, mute, and vegetative state. The significant medical surgical history is that the patient has been chronically unwell, but was sent 2 days ago. She is a known patient with a brain tumor. Under medication, relevant past medication, there is none. The current medications she's on oxygen therapy at Phenobab 200 milligram IV BD for 5 days, paracetamol 1 gram IV for 5 days, Ringer's lactate IV alternated with dextrose 5%, amoxil 1 gram IV for 5 days, IV mannitol 500 milligrams BD. The social history and pertinent family history, the work status, the patient is unemployed, occupation unemployed, education, secondary level, socioeconomic class low, marital status widowed, lifestyle habits unknown, relevant health conditions in close family members, no history of any chronic illnesses. We don't have the advanced directives here. We are not yet doing them. Then the review of cystics, the vital signs, temperature was 38 degrees Celsius, BP is 113/75, pulse 137 beats per minute, and the saturation is 89%. The pain score was not assessed. Then the ECOG functionality score was 4. She's bed confined and with self-care deficit. Yes, 4. Then the symptoms we have with the scores for pain, we don't have. Then dyspnea, it's 3. Anxiety 3, agitation 0, depression 2, drowsiness, fatigue 3, nausea, vomiting 0, anorexia 3, constipation 0, dry mouth 3, poor mobility 4. Then the focused investigations, currently we did CBC, creatinine and urea. The HB was 7, creatinine was 100, the urea was 10.7. Then my special investigations was the CT scan brain, and the findings were brain mass. Then our further plans discuss the condition with the family, prognosis also discussed with the family, and counseling provided. That's all.
Thank you, Bongegile. Thank you so much for the case presentation. I hope it was audible enough to everyone. Yes. We're sorry that the projection is not very clear for some, but if ever you have something which you didn't see very well, we can just go back to wherever you want us to go. Well, at this point in time, I would love us to say something about the presentation. If ever you have a question, feel free to write on the chat box or raise your hand. If ever you have a comment, do the same. Recommendation. So this is our platform, colleagues. Let us all participate and help our colleagues from Tatikulu wherever you see a gap where they may improve. It can also benefit everyone from our different facilities. So let's participate, colleagues. And here is our case. What can we say about our case from Tatikulu Government Hospital? My team, if ever they've got something to say, feel free to indicate, and I will give you the platform. This is our platform to communicate and to learn. So feel free. You can also use the chat box, colleagues. The chat box is ours. How can we help? How can we improve in helping our clients here? If ever you see something that was a gap that was never done, how can you advise our colleagues from Tatikulu to intervene and to help best our clients here? Okay. Okay, thank you. Thank you. I can see a comment from, or is it a question from Mr. Mvila? Mr. Mahlangu, can you please read that for me?
Mr. Mvila is asking Bongegile that is the brain tumor benign or a malignant?
Okay, thank you. Thank you so much, Mr. Mvila, for that question. Bongegile, are you there to respond to Mr. Mvila's question? What can you say about the brain tumor?
It's a malignant tumor.
Okay,
it's a malignant tumor.
Thank you for the response. I see another question. Mr. Mahlangu.
Sir, Mr. Mbula asking, sir, how long has the patient been diagnosed and the duration of hospital stay?
Thank you so much, Mr. Matang, for reading that question. Thank you, Mr. Mvila, for the questions. We deserve an award for the active participation. Bongegile, may you please respond to that question, or Bongegile, are you there? So feel free, colleagues, if ever you have got something to say, you may also, or to aid or to advise the article team to improve on. Colleagues. Bongegile. Okay,
We have a question or a suggestion or
okay.
That says, thank you for the presentation, Bongegile. I just want to find out about the pain score. How will the patient get his rightful pain medication without the pain score being assessed?
Thank you, Mr. Matang, for reading what school has just asked. Colleagues, this is a flow for everyone. I think this question would apply to everyone because we do assess. So maybe you can best advise the flexibility team. I see a hand from Mr. Mvila. Please feel free to unmute yourself, Mr. Mvila. And
thank you, Chair. I'd like to thank Bongegile once again for presenting this case to us. Although I think because she presented using this form, vital information is missing. But I want to thank her for highlighting that it's a malignant tumor. So in other words, it's cancerous. So doing a craniotomy for such a patient, I think it won't help much, especially, but we would like to know how big the tumor is. But now that the tumor is altered the Glasgow Coma Scale, that is altered the consciousness of the patient. So the patient is now unconscious. It means maybe it's at an advanced stage. So I think we'll just do palliative care, and my colleague is correct to ask about pain management. We manage pain and do the best we can in the condition that the patient is in. Thank you very much, Tim.
Thank you very much, Mr. Mvila. We really appreciate your participation, sir. I don't know whether Bongegile is still there to say something. Okay, on my side, I have Spongile. I think he has got something to say as well. May I just give her the time?
Thank you, Ngambule. Just to add on what has been said by Mr. Mvila, the assessment which Mr. Mashangu told us about is important because yes, our patient we normally say in a layman's language is a hemorrhage now. The assessment which Mashangu said is important, and since the patient might be in pain, we can do something. And remember, whatever we give, that pain relief medication is also being titrated according to the assessment and the symptoms. Thank you.
Thank you very much, Magesibongile, for your comments. Is there anyone who would like to say something? Bongegile, I think you are there now. There was a question from school about the pain score. Colleagues, anything else? Anyone? Is there anything that you would like to say or ask or contribute? Feel free to use the chat box as well to say anything. Anything, colleagues, from my side? Mr. Bongi, do you have something to say, sir?
Okay, thank you, Tim. I think pertaining the pain score, though there is nothing that shows something, but in the prescription, in the case, I saw PCM, which means there was something done about pain, though we're not sure how did they get to the PCM party. I think there is something that was done about pain, coming back to school. Maybe Cisco will elaborate about that, but I think there is something done about the pain of the patient. Because there is PCM in the prescription of the patient.
Thank you very much, Mr. Mabuza, for your comments. Thank you. Bongegile, do you have anything to say concerning the pain score or pain assessment? Okay, I think we have a challenge with Bongegile, colleagues. To forgive us, maybe it's network problems, I don't know. But I think he's having challenges in communicating with us. So I would like to ask you as well to add anything or advise the Hlatikulu team, guys. This platform is to help one another improve and do what is best for our clients, whether in a facility level or at home or whatsoever. So we interact as healthcare workers to help one another in such a platform. Okay, I'm happy that Mr. Mahlangu has got something to say. Over to you, Mr. Mahlangu.
Thank you so much, Bongegile, and thank you so much, everyone, for the feedback. And thank you so much, Mr. Mabula, for the advice. I saw that the concern was that the family members are in request for an operation with the surgeons made it clear that because of the prognosis and the state of the patient, the surgery or the procedure might be futile. So I will say in my summary, I will say at this point, it appears that the patient now is approaching the end of life, or is already at the end of life and death is imminent. You will find that putting one into theater at this stage will be very expensive, though we are not yet aware with how long has the patient suffered this pain. But I would say at this point, it would be best if Hlatikulu will engage on spiritual support for the patient and the family, and engage on the distressing symptoms assessment and control at this stage, and include the family support at this time and counseling as they've stated, and identified the advanced care directives. I think the patient and the families, they are in this state in demanding such vital treatment because the advanced care directives were not well explained. I think the facility has to, as the palliative care team has to work around on finding out how best they can have advanced care directives for the patient. Especially now the patient is unable to speak, so it becomes a very complicated situation on how to manage the patient because we don't know the advanced care directives with this patient. And this patient is end of life, so I guess end of life care has to begin and be initiated. So the counseling will be okay. But I think at this time, referring this patient to a home-based unit like hospice at home will be beneficial for the family and the patient itself. And the issue of admission will be accepted if admission will be of beneficial to the patient. Because if we are aware of the will or the advanced care directives of the patient, we will now know if admission will be feasible for the patient or discharge will be better because the patient might die at any time. So I think that one will be very best to be linked. And the issue of pain assessment will be very important in this time around to know where and how the patient is going to be managed, because at this time we find that the issues of pain control is very important. And I don't know if the patient is mute, but is the patient able to swallow and eat? Because Panado, most of the time you find that it comes PO. So you will be worried of how the medication is being administered, because crushing medication, especially tablets, it's dangerous to the patient because the dose becomes so very high. So, and the metabolism of the drugs becomes changed as it was designed. So I think there's a lot that is there, but I would advise the team has to sit down and look around the plan of care and engage the family. Instead of explaining prognosis, sit down with the family. I guess one of the things that is missing is how much aware the family of the diagnosis and the prognosis itself. Because I think one of the things that makes them confused is the issue that they are not involved in the beginning of the treatment and they're not aware of the diagnosis and prognosis. That would be my suggestion to the team that work around the issues of advanced care directives and then including the family across the journey, because death might be imminent based on what I'm seeing here and in Mr. Villa's comments.
Thank you very much, Mr. Matlangu. Thank you very much for the recommendations and your comments, sir. I would also want to add on that previous sections, we talked about a project decision maker. So it's very important that someone who's unable to talk has someone he has identified as a project decision maker who will make decision on his or her behalf when he's unable to communicate. Thank you very much, colleagues, for joining, and thank you very much for attending the show. I think Mr. Matlang will send a feedback link on the chat box. You are all invited and expected to join the link, to enter the link so that you can make sure that there's a feedback link on the chat box. Yes, please make sure that you join the link. I will ask Mr. Matlang to tell us about the next not presentation per se, our next session, and the topic for our next session. Thank you so much for your time, and thank you so much for participation.
Thank you so much, Mr. Msutu. Our next presentation will be discussing on the communication. So we are closing today the ethical dilemmas that we are encountering in palliative care. I guess those who have faithfully attended the session today have, since we began, have understood the dilemmas that have made us not to give our patients the best palliative care. And we are encouraging that if ever you have a challenge, you continue to share it during session, that what challenge you face, so that we can assist you on addressing the challenge. Otherwise, today marks the end of ethical dilemmas in palliative care. In our next session will be on the 4th of May. So it means every other week we have a session at 1300. We will be starting on the most important and the pillar of palliative care. If you remember, when we introduced the program, we say one of the pillars of palliative care is communication. So we will be taking the theme communication in the next 3 months, which means it's May to July. So we'll be discussing topics under communication. And we appreciate those who are sharing cases. Continue to share cases with us. It helps us to learn more and understand what is really happening on the ground, especially in the country. So in our next session on the 4th of May, we'll be discussing elements of communication, and we are going to share the registration link with you. If ever you have not received the registration link from Eswatini Hospice at Home, kindly contact Mr. Mahlangu on his WhatsApp number 79297140. You will then get my so that I can add you, so that you can get the emails. Otherwise, you will be getting the emails. In your invitation links, we usually share with you a feedback link and the resource materials that will be presented today, and the video of this session will be presented to you. So we kindly request you to always click that feedback link that has been shared right now and share the feedback for this session with us. Thank you so much, and we wish you all the best, and we are going to see you in the next session. You are free to invite more people to join us so that our clients all over the country can benefit from palliative care, when we are all sharing the skills and knowledge, and we are all capacitated in providing palliative care. Thank you so much, colleagues.
Bye-bye. Thank you.
Bye, everyone.
Thank you. Bye-bye.